Try not to step too far forward when you're talking. Just you get a camera shot.
Where do you want me to go? Just here.
So step to the left.
Left.
Step to the left. Sorry. You can step. So you
That way.
can go anywhere there. Just that if you go too far over there.
Okay.
Not too close to me.
Okay.
Stay away.
Okay. I will start then. I'm going to take a photo if that's okay. Do you mind? Yeah, okay.
Want me to get my one?
Well, you can, yeah, because it's crap. Mine's crap. Yeah. Mine's broken. Mine's broken.
Anyway.
Say hi. Say cheese.
Do a long one. I don't know. Well done.
Cool. So I guess we're all ready to start. Yeah. Are you all looking forward to the spinal manipulation and mobilizing? Yeah. I guess, so thank you for SJ for hosting the course in Glasgow, which is brilliant. It's my first time in Glasgow. Not my first time in Scotland, but I've been to many places. I was in Fort William recently and the Isle of Skye on my motorbike. And I've done the North Coast 500, partly in a motorbike, mostly in a motorhome. So it's quite good fun. I was actually in the army as well in Inverness. So I was in the British Army, but I was posted in Catterick. But we went to Inverness for, I got no idea why we went, but it was great. Yeah, I was quite young at the time, so we was more interested in going to the bars, yeah, and stuff like that. So that was quite good fun. So we have a lady from Poland, yes. So I know a little bit of work because I was teaching in December in Białystok, up in the north near Belarus. So that was quite good. So Dzień dobry. We have a gentleman from Romania. Yeah. I'm looking around because I know most of you from the few. So I guess most of you from Scotland. Anywhere different? No. What? Manchester. Okay. Did you travel up? Okay. Oh, well done. And how long did that take you? 4 hours. 3. Last night or today? Yeah. Okay, good. When I'm teaching in Manchester. All right. Do you know each other? No. Would have saved a journey. Would have saved a car fare. Yeah. But no. When I've taught in Oxford or in Swindon, I have a few Scottish people who come down. There is a lady, Maria, and I just can't believe she does it. She gets on like the night bus, so she just sits on a bus. It's not like sleeping because it's so cheap. And she travels all night, so she gets to me about 8 or 9 in the morning. And then she does my course and gets the bus back. And I got another guy who will just literally, he leaves at midnight, like from somewhere north of here, and drives down, does my course and drives home. I'm like, why didn't you just come the night before and just sleep and rest and recover? Because during the course, most of these people are like, yeah, they're all sleeping. Okay, so we are going to be filmed a little bit. Is that okay? Yeah, so SJ is going to film. So as long as we have permission to do that, and it's no problem. So you've all got a set of notes in front of you. You've all got a leaflet of some of my courses. I'm not here to sell you anything. Mind you, I do have some books, and I do have a card machine. So, and I don't want to take them back to my car. So I'm not sure what price they are. It's just like almost like make me an offer. Mind you, I did sell one to you for 20. But yeah, but if you wanted a few books, they're all there. I'm actually writing another one on this subject. I think my course notes are quite nice. Mind you, as I get older, my eyesight's not so good. So the font is a bit small, but most of you are younger than me, so I think you'll be okay to read it. If not, put on some +2s, and you'll be okay. If you want this set as a PDF, then just email me later or tomorrow, and I can send them to you because you might want them on your laptop or your iPad. Also, when I go through my PowerPoint, a lot of the stuff on there is not in your notes. It is taken from this book. And in a year's time or 2 years' time, if you did this course again, because a lot of people end up doing this course a couple of times, then I will be giving you a book on spinal mobilizing and manipulation. This is part of my pelvis, and a couple of the stuff we will do today, or the chapters, if you like, are taken from here. So the bit on spinal mechanics, like for instance, costings on our page, if you just look in your notes and look at this page, can you see there's a couple of pages like this, they're all similar. It's towards the end. So this would be one way of assessing the spine, but it's taken from the whole chapter on spinal mechanics. I'm not sure it is, I think it's chapter, there you go. So I'm actually palpating, like a real person rather than like drawings on here. And then I explain it in a lot more detail. Like today, the first hour's theory, then is practical the rest of the day. Whereas this, it took me 6 months to write one chapter, okay? Because it's quite technical, it's quite full on, but it's worth trying to understand it, okay? So if you want it, just send me an email and I'll send you that chapter and I'll send you the notes from today. And if if anything else I find is relevant, I'll send you that as well, okay? So just bear that in mind. Now, we've got a couple of physios. Do you have any more physiotherapists? Yeah, so we've got 4 physios. So potentially for you, today is a little bit different in terms of like insurance compared to the majority of you. Do you have any osteopaths? Maybe one, me. Yeah, no chiropractors? Okay, so the majority, more than likely, will be sports therapist, sports massage therapist. Yeah. Now, on the table somewhere, you have got a little leaflet. If you're not sure about the insurance, because this course used to be part of my diploma, but because the majority of sports massage therapists didn't really want to do the manipulative technique, I took it out and I put in the glutes. Okay, but it is my busiest course. So that means that all of you will plan to use the techniques I will show you. If you are going to do this bit, okay, this bit's okay. The mobilization, you don't need to worry about it so much in terms of insurance, because if you're a sports therapist, you're already mobilizing anyway. If you're a sports massage therapist and you're mobilizing someone's shoulder, you're already mobilizing and it's not a problem. However, when it comes to this bit, it is a different story. Okay, so if you say you are going to utilize spinal manipulation, it doesn't matter how you say it. For a physiotherapist, it would be known as a grade 5 technique or grade 5 mobilizing, but it's not really a mobilizing anymore. It is, you've crossed that line, you're in like a different room, okay, and it is a manipulative technique. I won't call it a manipulation as such. I will call it something else like a HVT. And a chiropractor will call it something else, and he will call it an adjustment, like a spinal adjustment. Okay, so the physio will call it a grade 5, the osteopath will call it a HVT, and then the chiropractor will call it an adjustment. But they're all a similar sort of technique, but it's still manipulation. And if you are going to use it, and you're going to say you're going to use it, and you're going to promote and say you're using it on your website, and people are coming to you because they want manipulative techniques, then obviously you have to have the appropriate insurance. Some of your insurances will already cover you. Bail-ins won't. They have done in the past, but because it's only a one-day course, it's not a qualification course as such. But BGI will say, you could send them the certificate from today, so you get a piece of paper, but it doesn't physically say you are qualified. Okay, it's an attendance course with myself. I don't examine you, I don't assess you, because it's only one-day course. It needs to be a lot longer. Osteopaths tend to spend many years studying, the same with chiropractors. Okay, so I will try to teach you as much as I possibly can, and that's why I do an advanced course. Yeah, so it consolidates what you learn with me. I'm not going to be doing it here for a while, but I might do it in the future. So just bear that in mind, okay? So if you are going to use the technique, then you have to look at, does your insurance cover it? It does say on my website before you book, BGI, they will charge you probably treble what you're already paying. The physios, you don't have to worry about it, okay? Because it's already part of your remit, if you like. Whereas the sports therapist, you have to decide on the way you're going to go. But not all of you, because I teach this course often, I mean, I was in Dubai last week teaching 23 students, but they're all physios from like different countries like Iran and Palestine and Egypt and Tunisia, just went on and on and on. Yeah, so it was really good fun. So that's, in the different countries, not really an issue. But in UK, it can be. Okay, so just consider, but they will insure you for all of it, like acupuncture, the sports massage techniques. If you learn cervical manipulation with OMT, Jimmy and Giles in, say, London, they will cover you as well for that. So from me, a lot of people will do the OMT, and the OMT will come to me. Okay, so that's, you know, a lot of people. I mean, there's another guy in Norwich Way, and he also runs a 5-day manipulative course. There's another guy called David Lintenbaum, and he's teaching cervical spine as well. But he will only teach experienced therapists. Okay, that, and mainly osteopaths and chiropractors, because it's protected and they already are manipulating. I'm not really putting you off. I'm just making you aware. But it's not like it's a huge commitment. It's only it's a 1-day course. Okay, and if I'm truly honest with you, I'm not going to lie to you. All of you probably are here to learn this bit. Yeah. But when I show you the technique as we go through the day, when we finish at 4:30 to 5, most of you, when you leave, you'll be like, some of you will be like, I'm not really sure if that technique is for me. I think, Manda, you were saying yesterday, you want to learn a bit more because you work, say, in a chiropractic clinic, and you want to understand what they do. And you were saying, like, you know, you might not be able to do all the techniques I show you, but it makes you more aware of what these other people are doing. Okay, so, but then some of you might already, anybody already manipulating? Just mobilizing, okay? Yeah, so it's a scary, scary subject. And when I show you the techniques, then it is like, it's like climbing a ladder, 1, 2, 3. And then obviously the 9 to 10, the 9 to 10 will be the cavitation, the click, okay? And then we'll discuss what that is as we go through. But most of you will want to learn that technique. But the 1 to 9 is quite easy, potentially, but it's just that last bit. And I cannot teach you that last bit. I cannot do it for you. I will show you and guide you and fine-tune you, but I cannot physically do it for you. It's like when I, you know, because I probably manipulated 100,000 patients, maybe more. I'll probably end up manipulating most of you today. Yeah. I don't really want to, let's say, like Costin is doing it. Is it Callum? Callum? Yeah. So let's say, and you were trying and you might not be able to do the technique. Then you say, oh, John, can you do it? So then I'll do it, yeah, for you. And that's the way it goes. Then I'll probably demonstrate another technique. But once it's done, that's it. Okay. Whereas a mobilization is like, in the field of physical therapy, there is the 3 M's. Okay, we've got the Maitland, we've got the Mulligan, and we've got the Mackenzie. Okay, they're all friends, okay, from the southern hemispheres. So little techniques like nags and snags and mobilize with motion. Okay, so they're all mobilizing type of techniques. So they will say, feel the facet joint in the neck, and they might do like a mob, okay, onto the facet, but they might do it 10 times. Back off and repeat 10 times. Whereas a manipulative technique done by the chiropractor, how many patients a day will you roughly see? 5 to 10? Maybe a bit more, maybe a bit less. Okay? My friend who's a chiropractor, how many patients a day will he see?
20.
65. Okay, 65 a day. Maybe more or less. Okay, so it just depends. So they don't do any mobilizations. Well, they do in some respects, but the typical chiropractor, like my friends from the Anglo-European School of Chiropractic in Bournemouth, the treatment is very, you know, a friend of mine in Wales, I think in about 4 days, he does about 500. Okay, and he has 4 couches all set up in one go. So he just goes from 1 to 1 to 1 to 1. And as he manipulates, he'll say, pay your money on your way out and I'll see you in 2 days. Okay, and then the next one. So he's probably seeing, I don't know, 10 an hour, maybe more. Yeah, so it doesn't really have a set time, but it's purely mechanical adjustment. I was saying yesterday when I was teaching a course about muscles and we test muscles, but one of my friends, who's also a chiropractor, will say, and we almost have like a discussion, whether it's a debate or discussion, it doesn't really matter. Okay, he will say it's never, ever, ever, ever the role of a muscle or the fault of a muscle is why the patient is in pain. Everything relates to this. Okay, 5-year training as a chiropractor or osteopath. Osteopathic technique is very different in some ways because it tends to be a bit longer. We do soft tissue work as well. We might mobilize. Yeah, whereas a typical chiropractor, doesn't matter if you're trained in UK or US, is purely and utterly relating to this. Okay? Yes, they can maybe do an adjustment of an elbow and a shoulder and maybe the tib-fib joint, but typically they will manipulate the OA joint, okay, the occipital atlanto, the AA, the atlantoalaxial joint, the C7T1, which is known as the CD junction or the CT junction, because thoracic spine, dorsal spine is a similar sort of name. Then they'll do the thoracolumbar, T12L1, LS, the lumbosacral, and maybe the SI joint. Okay, but it's almost a similar sort of process. Okay, click, 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 click. When I saw my friend in in Exeter, I'm naturally saying, do you want me to strip down to my shorts? And he's like, no, just stay as you are. Okay, his assessment of my pelvis, holds my pelvis, and that was it. He goes, oh, you're a bit stiff in that right SI. And even when I do it now, I think, yeah, I think you're right. I'm almost convincing myself I'm stiff. And that was it. And I spent 2.5 years writing a book on the pelvis. And my friend just did that one technique. I went, yeah, still feels a bit stiff. But anyway, so he lays me on my side, no warming up, no soft tissue work, no thumper massage, yeah, no massage guns, no oils or creams. You know what I mean? He was just literally laying his side, drop, the other side, drop, T-spine, okay, thoracic spine, breathe in, breathe out, butterfly spring, turn over, loads of extension, rotation on my neck. I'm like, wow, that's quite a lot of rotation to my neck, that one. And anyway, right over here, full rotation, then the other side, and as he finishes, he looks at his watch and he goes, media volume set to 100. Oh, sorry. That's quite good time, isn't it? Yeah. And he said, 2 minutes, 20 seconds. That's not bad for me. Yeah. And I'm saying, if I was your patient, what would you do now? He said, well, I'd say, on your way out, it's a Monday, book in for Wednesday. Pay you 45 quid, yeah, and book in for Wednesday. Wednesday comes, book in for Friday. 3 times a week for a month, twice a week for a month, once a week for a month, once every 2 weeks for a month, and it just goes on and on and on. So he said the treatment will cost you about 800 to 1,000. Yeah, and we recommend that you'll have 25, 30 sessions and sign on that dotted line. Okay, rather than saying, hopefully we can help you in about 3 to 4. Okay, you've paid for 30. Okay, yeah, but I don't need 30. I need 3. But it's preventative. When I looked after the boat race team in Oxford, the Canadian chiropractor comes over, and the Canadians will want treatment whether they're in pain or not. But the problem is the Oxford University will not pay for that because they only pay for when these boys and girls are in pain. Okay, see John when you've got a bad back or a bad knee or bad hip. Okay, but can we not see him to prevent our back from getting worse? No, it doesn't work like that here. Okay, but in Canada, the Canadian chiropractor would treat you to prevent, and he would be adjusting you every day. Okay, so they basically, my friends who are the Canadian Olympians would say, we train and we have an adjustment. We train and we have an adjustment 2 or 3 times a day, sometimes. Okay, yeah, and you think, wow, is that good or bad? I don't know. Yeah, okay, so I'm just trying to give you an idea because I've probably met so many chiropractors. I've probably taught more therapists than most people. Yeah, so I've got lots of stories to tell about where I've been. I was in Dubai last week. I was in Costa Rica a week before. I was in Poland in December. So I meet thousands and thousands of therapists. But I prefer Glasgow. Okay, and I'm from the valleys of Wales, so it's a similar sort of weather. I'm used to all this. Yeah. Okay. Now, let's run through the theory bits, and then we can get on to the practical side. A lot of people who offer spinal techniques will say, let's just get on and do it. When I did a spinal course, I was an osteopath, and I finished mine in 2003, so I did 5 years. But when did they start teaching me manipulation? Any ideas? It was a 5-year course. The 3rd year. Okay, so the 3rd year. So I'm on an osteopathic course. It's costing me like, I don't know, 8 grand a year, 10 grand. And I'm saying, are we doing any manipulations today? He's like, John, it's the first day. I said, I know. Are we doing any manipulations today? He said, No. We're doing them in the 3rd year. 3rd year? I said, there's no way. I said, I can't wait for 3 years. Anyway, so I'm on a course in Cardiff, like within a month, and I'm doing a 5-day manipulative course. the people on the course weren't like yourselves. There's no physios. They were just, the week before they did a skin skating course, okay, like a massage course, okay? That's why I call it skin skate. It's like an, I don't know, like introduction to Swedish massage. So it's a bit of effleurage, bit of petrissage, okay? And then now we got this osteopath who's 20 years experience was teaching manipulative techniques. And the first technique, okay, so these people, the week before the massage, were like, they worked in an office, or they did this, so they got no idea about anatomy. So when the osteopath was talking about the OA, the AA joint, the vertebral artery, yeah, the cervical, the ulnar nerve, and everyone's like, I got no idea what this guy's on about. Yeah, but the first manipulation, okay, the first one was the upper cervical complex. The first technique, okay, not the last, the first one. Now, if you're going to cause a stroke, there's a potential for a stroke to be caused by the upper cervical spine. It's quite rare, okay? But when you watch these massage therapists, okay, manipulate the neck, you can probably see how a stroke could come on quite easily because these people had no idea whatsoever what they were doing. Okay, so they should not have been on, and maybe I shouldn't have been on the course either, but I was already teaching sports therapy, so I knew a little bit more than maybe what they did. So when this guy was trying to, and he used that word, John, can I have a go on your neck? I'm like, oh God, if you have to. Okay, so he's literally feeling my neck and he goes, I've got no idea what I'm doing. Okay, so he's like, he goes, I can feel your skin. Okay, but he said, I don't understand what the facet joints are or this or that. And then he said, I'm not sure what I'm supposed to be doing. I'm supposed to like hold your head and just turn it fast. I said, I'm like, no, not quite. I said, you have to look at like coupled motion and you have to understand the biomechanics of the neck, you know, the type 2 motion. He's like, I got no idea what you're doing, John. Can I just have another go? I'm like, so you try, and he literally would try to force my neck. He said, you hear a click? I said, no, I didn't hear a click. He said, can I have another go? I said, no, not really. Yeah. So, and that's just the way the week went. It was just like, it was just ridiculous. The next day when I walked into the classroom, I said, no one's touching my neck today. Yeah, because I was in so much pain. I think I had a bit of neuro pain in my arm. Yeah, because he's trying to force me. Okay, so, and I thought to myself, if I ever teach manipulation, I would never teach people where they are at a lower level. You know, you have to be a set level, yeah, to be on. Okay, so, and that's why I enjoy teaching it, because I'm no good teaching people where they've just started. I'm better to teach people where they're on the ladder somewhere. Okay, it doesn't matter if you're at a quarter of the way or halfway. I'm better to take you to that next stage. Now, let's look at the spine. Okay. I will ask you some questions. It's nice if you know it, but don't worry if you don't. Not many people want to speak up sometimes when I'm talking because they think, oh, God, am I right or am I wrong? So when you're looking at, say, the treatment as we go through today, like people will say about like the discs. Yeah. And I would expect you to know about some sort of like spinal pathologies as we go through because they might be contraindicated. When I teach in Dubai and you've got a bad back, you will have an MRI scan. Okay. Every single person with a bad back has an MR scan. I'm like, that's just brilliant in some ways. Yeah, so at least then you know what it's not and you might know what it is. Okay, most of them might say disc pathology, yeah, like an annular tear, yeah, like, you know, like disc bulge or protruding bulge or herniated disc bulge. So at least then you might say, well, it's maybe coming from that sort of structure. But when someone has pain to the lower back, then we as a therapist, we're almost guessing in some respects what we might think it is. And then maybe what we think it is might not be that, okay? Because it might be other structures. So, but then you still would need to understand, you know, what type of conditions can be associated to the spine. Like, for instance, if you've got, say, a 15-year-old male and he's playing cricket and then he contacts you and says, or let's say the dad contacts you, says, my son is playing cricket and he's got a problem with his lower back. So when he's, say, extending and rotating, he's getting sort of like pain to that sort of area. And you think, oh, I can treat that. Yeah, so you massage him and you loosen him, think, well, I'm going to have a go at manipulating him. But then when he sees somebody else who says, I'm not sure if I would treat him yet because I would want him to have something to confirm what I hypothesize. And then if it's a diagnosis of my hypothesis, then would I be manipulating him in the first place? What condition do you think I'm talking about? The physios would probably know because they probably did quite a lot of it. So a 15-year-old male, let's say he's a fast bowler, or we've got a lady who's a gymnast and she's doing loads of extension. Okay, so you were saying that word slip disc. I'm not. Yeah, so there's probably no such thing anyway. Yeah, because the disc physically doesn't slip. Anybody have a go?
I know what you're on about. I can't remember what it's called.
Oh no, the morning gone.
Yeah. What was that? Okay, let's just answer that question. Okay, so if you said ankylosing spondylitis, yeah, it doesn't normally find it in a male who's 15. Normally, with ankylosing spondylitis, it's normally like 20s. Okay, it can be 17 to 40, but give or take, it's like a man who's like, let's say, oh, Callum, how old are you? 23. So Callum sees me, he would come in, not because he's the fast bowler and he's got pain and extension. He would say when he wakes up in the morning, the left and right SI joint is stiff. Okay, he says to me, I don't feel like I'm 23, I feel like I'm 43 or 53. Yeah, that sort of thing. Okay, he's like, oh God, my back is so stiff in the morning. So then if he says that to me, every morning is the same, and it's the left and the right SI joint, would I treat him? Maybe not, because I'd send him to the doctor with a letter saying, I think he's got ankylosing spondylitis. Ankylosing is diffuse, and the spine is inflamed. So spondylitis is an inflammatory spine, and eventually it will fuse. Okay, it's through a process called enphesopathy. I would send him for a blood test. The physios, what's the blood test called? Yeah, what's it? Yeah. What's the blood test? What's that? So the blood test I'd send him for would be HLA B27. Okay, so I'd send it to the doctor saying, I suspect he's got ankyspond, and he'll be under the rheumatologist now. Okay, the rheumatologist will do the blood testing for the HLA, which is a human leukocyte antibody gene, B27, and he says, yes, it's positive in 90% of the cases with AS, ankyspond, and then more than likely they'll say, Callum, you need to go on these DMARDs. What does a DMARD mean? Disease-modifying anti-rheumatic drugs. So he'd be on like this horrible drug called methotrexate or sulfasaline. Okay, so suddenly now he's not seeing me anymore, but he came to see me because I'm an osteopath and I treat bad backs. Okay, but I'm not treating him because it might be contraindicated. I could treat him and massage him and loosen him. Okay, I might be tempted to do the odd gentle manip. Okay, but in reality, he's now under the care of somebody else. The fast bowler who's 15, what condition has he got? Which one? Not quite yet. Okay, not quite that one. Let's use this one. If this is one vertebra, okay, so you've got the spinous process and the vertebral body. If we have a condition Amanda just said, and it does this, the vertebral body slips anteriorly. Okay, the spinous process stays where it is, it's normally L5, and then we have a slippage going forward. So that would be known as a spondylolisthesis or listhesis. So a listhesis, I'm going to write, but it's in your notes in the first few pages in the contraindications. So if you've got a listhesis, it means you have a slippage, and it could be a grade 1, 2, 3, and 4. Okay, so if someone walks into clinic says, I've got a spondylolisthesis diagnosis, you're like, well, would I be manipulating them? Grade 1, 2 is relatively stable. Grade 3, 4 is relatively unstable. Okay, I'm not sure if I would be. Okay, so, it'd be a contraindication, but like, I think I'd be leaving that one alone. Yeah, personally. Now, before it gets to a slippage, it might just be a little fracture. I will leave this out for you to have a look. There's a fracture on the side. You won't see it unless you have an oblique x-ray. So before it becomes a slippage, it might just be a defect. And that defect is known as a what? A spondylolisthesis. So a lysis is like a defect of the, which bit? Of the pars. Okay, so the pars interarticularis. Okay, so that's where the fracture would be. But because where the pedicle comes out, so you've got the pedicles and there's part more of the lamina. The light. Yeah. So it's called a fracture or defect of the pars interarticularis. Okay, the pedicles are like the stumps that comes out from the vertebral body. Then it continues for the neural arch around here. So if this arch, let's say, has not truly formed, what would that be called? If you have a gap. But you might not know, and it's only picked up routinely. Okay, so they're checking for A, but they found B. Oh, by the way, we found a spina bifida occulta. Okay, so that's a lack of the neural arch forming. Okay, when you think, well, would I be manipulating that one? So you have to ask yourself that question. Okay, so that's what I mean is, in Dubai, if you have a scan, it will find all these. Yeah, whereas in UK, you're like, well, let me have a go. Okay, because most people would say that.
Somebody come into your clinic with a spina bifida.
Yeah.
Or the inside the spina bifida.
Yeah.
Spina bifida. Would you be manipulating them?
I don't know. I might be manipulated around it, but I'm not saying I would manipulate that level. Yeah, you normally have like a hairy patch around it. Okay, that might indicate.
Mobilizing it.
I might be tempted to mobilize. Well, I might be tempted to mobilize like the hip area. Depends what they're presenting with. You know, is that area causing the symptoms? Maybe it's not. Okay, maybe it's not causing the symptoms. Okay, yeah. So, you know, just bear in mind some of these conditions that people will say they have. Okay, and then you got to ask yourself a question: is it in my remit to manipulate? That's why it is safer to mobilize, yeah, because the chances of causing a problem is a lot lower, and if you decide to manipulate, the chances of causing an issue is a lot greater. Okay, if in doubt, say, I'll refer them to somebody else. Okay, if you've got an osteopath in a clinic or a chiropractor, yeah, maybe just say, can you assist me? Can you guide me? Yeah, can you have a look at my patient because I'm not sure what's going on? Yeah, and things like that. Okay, a routine X-ray. An MR scan possibly. So just you know, and then we can talk about contraindications all day, every day. Yeah. So, but we're not going to. So in terms of the spine, you have to understand a little bit about the motion of the spine. You know, because I teach this course often, and you know, and I go to clinics, and I go to a clinic, and I'm not teaching a sports therapist. The owner of a clinic wants me to come, and I've done it 3 or 4 times now, and I've got students there who are therapists. They've done a sports science degree, okay, or health and science degree. So they've got a degree. But the idea is that the chiropractor who runs the clinic is getting me to teach his staff how to mobilize and manipulate. And a lot of them will be using the activator, which is like a device to change the position of the vertebra. Yeah, it's like a spring, okay, and it shoots in. It's called the activator. But they call themselves a spinal therapist. Okay, so they are known as a spinal therapist. So the chiropractor will, when the patients come in for treatment of the spine, they'll be referred to this person who's done a 1-day course with me and done a sports science degree, and they might be using the activator. But they are classified as the specialist in the spinal vertebra. Okay, so when I said to these students, I said, how many discs do you have? The question to you, how many discs do you have? 23. Okay, so you got 23 intervertebral discs, because lots of patients will know that. And lots of patients will have conditions that the person might not know that much about. Okay, like the spondylolisthesis, the spinal stenosis, okay, the ankylosing spondylitis. So you as the manipulator, okay, have to focus and then do a lot more study on the conditions of the spine if you are offering treatment of the spine. And you have to understand how it moves, okay? Rather than just saying, let's just do it, you have to understand how it works. Now, right, so these are some of the pioneers in spinal motion, okay? You might have heard of some of these, but it's old school stuff. Look at the year, okay? So 1903. 1903, Dr. Lovett basically looked at the spine and said, if our spine was a straight rod, which is not, and we bend it to one side, like the right, it only bends to the right, okay? Lateral flexion to the right and lateral flexion to the left. But Lovett said we don't have a straight rod or straight spine. We have a curved spine, okay? So we've got a curved spine. And then what he found now was when you side bend, he noticed it had rotation to the opposite side, dependent. Now, later on, Friat, and I've highlighted it and I've underscored it because Friat is where most osteopaths would have training in. So they will call it Friat's laws, Friat's principles, Friat's mechanics. So when you're talking about spinal motion, spinal mechanics, it's mainly come from Lovett, who instigated it, but Friat wrote about it Okay, wrote an article in 1918, Harrison Fryatt. So when we're talking about the motion of the spine, he was the main pioneer. And then he defined different aspects called neutral mechanics and non-neutral, type 1 or type 2, which I'll explain shortly. So what he said was, if your spine is in neutral, now, if you teach Pilates, you might say to the patient, I want you to adapt neutral spine. But if you think about what neutral is, if you extend your spine, you are extending to close the facets. And if you flex your spine, the facet joints are now opened, okay? So if you open the facets or close the facets, you cannot be in neutral because it is either closed or open. So neutral is somewhere between the two positions. If you have a neutral spine, according to Fryatt in 1918, when you side bend to the right, there is a horizontal rotation to the left. So they call it coupled motion. So side bending to one, rotation to the opposite. Okay, known as type 1 mechanics or neutral mechanics. However, if you put yourself into non-neutral, i.e. extension or flexion, Fryatt said, when you side bend to the right now, let's say you're in flexion, it rotates to the same side. If you're in extension and you side bend to the right, it rotates to the same side. So they call that type 2 mechanic or type 2 motion, principle 2, or non-neutral mechanics. Okay, so if you're not sure, towards the end of the notes, you have got a section on spinal motion. Okay, that's what I'm saying to you. My chapter, which took me 6 months to write, so on page 10. So on page 10, you've got them. So on the left-hand side, right-hand side, it just talks about 1 and 2, okay? So you've got some information there. Learning is slow and steady, okay? You can't be bombarded for days and days on it. A little bit, leave it alone. A little bit, leave it alone. So read a little bit, leave it alone. Now, there's another guy. We'll leave Nelson alone. Grakovetsky. Grakovetsky, Serge Grakovetsky. If you put that word on YouTube, you will see a video from 1988 where Grakovetsky talks about this again, like I'm trying to show you, but he does it in a different way. But he talks about the spinal engine. So he talks about the spine is the engine that allows locomotion. The arms and the legs are instruments of expression. Okay? And I'll show you a video of an amputee where he is walking on his ischial tuberosities. So he's not using the legs, he's using the movement of the spine in a type 1 motion. Now, when you're looking at the facet joints, let's say in the lumbar spine, the facet joints allow motion to occur in certain planes, but they will limit it in other planes. In the lumbar, they are more vertically orientated. So when L4 or L5 rotates, it is blocked by the vertebra next to it. So you only have 1 to 2 degrees of segmental rotation within the lumbar. So you only have 5 to 10 degrees, give or take. The cervical spine is very different because you've got full range of motion in rotation left and rotation right. But in the lumbar, you do not have. Okay? But you're able to flex happily and extend to a point. But rotation is not coming from the lumbar. So when you rotate, it's from the hip and the knee and the ankle and the foot and from your thoracic spine. But in the cervical, you can rotate because the facets are more horizontally located. So they glide over each other to allow you to turn. So when we manipulate, say, the neck, it is more of a rotation thrust. When we manipulate the lumbar, it is more of a side bending thrust because we don't have much rotation. The reason why you've got facets is they are like active ligaments. If you do not have facet joints, the spine would wear down very, very quickly. So by the time you are 30, you will have a condition called degenerative changes to the spine, which is called what? Spondylosis. Okay, so spondylosis is OA of the spine. The lumbar, it's only really L4 on 5 and L5 and S1. In the cervical spine, it's only 4, 5, 5, 6, 6, 7. 3 in the cervical, 2 in the lumbar. So obviously those tend to wear down more than other areas. as we go through, we'll explain. But you don't tend to get much OA or spondylosis, T5 or T6, L1 or L2, C2 or C3. Okay, so it tends to be in transitional sort of areas. The reason why sometimes I believe it's that area, like in the neck, the top part of the neck might get fixated for some reason because of a change of position. The head has gone forward and then the OA closes down. So when you turn in now, you turn from a different aspect. The lower part of the cervical, the C7, T1 is also fixated. So the only joints that can move is within that C4 to C7. And you wonder why you get spondylosis. So when you see these patients, it's almost too late. You've missed that opportunity to help in some ways because it's already deteriorated. And that's why sometimes chiropractic is good, because you could argue, does it prevent these things from happening? And maybe it could be. Okay? It's like if you've got a problem with your hip, the next focus is pelvis and lumbar. And then lumbar, where the triangle point is, if you like. Okay, so if you've got a problem with your lumbar, you might have a problem with your thoracic spine, or you got a problem with your SI pelvic hip area. Okay, because it's in a three-dimensional bowl. Okay, so the hip, like we did yesterday for half of you, okay, is so important to the function of your lumbar spine as we go through. Now, moving on. So some of these I've already done. So we've got the natural. So when we're looking at curvatures of the spine, so we've got one flex curve when you were in a fetal position in your mum's womb. And then when you have primary curve of flexion. When you are born and you stand and you lift your head, you develop your secondary lordosis curvatures. So you got two primary, okay, and two secondary. So the primary is the sacral nutation, which is in flexion. The thoracic spine is in kyphosis, okay, flexion. And the cervical and the lumbar is naturally in that lordosis position. Happy with that? Easy enough. Okay, so if you've got something like a flat back, if you can't see and you come closer, that's fine with me. If you want to film anything, that's fine with me. Or record, you carry on. Okay, it's you, of course. Okay, you know I do this often. It's about you guys, not about me. So from here, so when you're looking at, say, this one, so if you've got a flat back, the lumbar spine is naturally flexed, but the sacrum has gone back, so it's counter-nutated. Whatever the sacrum does, the lumbar does the opposite. So if the sacrum goes forward, the lumbar goes back. If the sacrum goes back, the lumbar goes forward. If the sacrum rotates to the right, okay, the lumbar rotates to the left. Okay, but we'll explain that as we go through. So this would be basically non-neutral mechanics, okay, because the person's in a flat back, flex spine. And vice versa. If you are hyperlordotic, okay, where you've got an anterior tilt, the lumbar spine is extended, then you might find, so the sacrum now is nutated, and you might find, one, it hurts in your lower back, but again, you know, you are walking in a non-neutral mechanics, okay, so it's unnatural to do that. So neutral, don't worry about this so much. I'm going to go through these quite quick, okay? So, you know, rather than just reading all of it. So just neutral is simply the facet joint idles between extension and flexion. Okay, so it's just a position of idle. And leave out. Now, so neutral. So when you side bend to the right, there is a horizontal rotation to the opposite side. Even like Eric Dalton, who's quite a famous rolfer in the US. So when he's assessing his patients, he will get them to side bend. Rather than saying, oh, I'm looking at the tightness of the quadratus lumborum, he will get you to side bend, and he's looking for a fullness on the opposite side. The patient side bends. This is the transverse processes. As you side bend to the left, you have a rotation to the right. So this transverse process is pushing the muscle back. Okay, so the muscle on the opposite side is feeling fuller than the muscle on the same side. I'll show you some pictures in a second. And it's known as a type 1 motion. So when you side bend to the left, there is a rotation to the right. I got a video, but I'm going to go through that quite quick. Like a scoliosis will be a neutral mechanics, but it's a group dysfunction. The lumbar all going left, rotation right. The thoracic spine all going right, rotation left. Okay, so you got two C curves, an S curve. It's hard to change if it's structural. Yeah, if the Cobb's angle is over a certain degree, like 45 to 50, give or take, more than likely you will be recommended for surgery where you have Harrington rods fixed. But now you prevent the motion of the spine. And if the spine is an engine, you have compensation. Okay, so surgery is good to a point, Yeah, but if you start fusing, fixing pins and plates, then you are allowing other joints to become compensation, and they become spondylitic in time. Okay, so when you are palpating the patient, you might notice the fullness is on the opposite side rather than on the same side. Okay, so for instance, if I side bend to my left and I feel these muscles here, then they are being pushed by the opposite, by the transverse process. Now, type 2, let's say for instance someone throws me a ball, let's say Doug throws me a ball and I go to catch it, I am naturally extending, I'm rotating and side bending to the one side. If I go to pick up something from the floor, I will flex, rotate, side bend to the same side to pick it up. But I don't want to be walking around like this all day. And I don't want to be walking around like this all day. There is a video on YouTube in the chiropractic clinic. No, yeah, I think it's Dr. Ian. Yeah, where this guy walks in that stoop position. He's like a 17-year-old. No one wanted to treat him. So basically, he's in that fixed position. You might have seen that. Okay, so rather than treating the lumbar, it is the sacrum, yeah, in that position. That's gone back, and the lumbar's gone forward. So his treatment was trying to change the position of the sacrum to allow the lumbar to reverse its curvature. But he would have been fixed in a type 2 dysfunction. So the side bending and rotation is to the same side. So you've only got to remember, there's a type 1, side bending rotation opposite, type 2, side bending rotation to the same. And that's it for now. Okay, so type 2, it looks like it's the same as type 1, but the rotation now is going to the same side. So now you can see that the patient cannot side bend so far, and the fullness is on the same side. So to recap, so neutral, type 1, non-neutral, type 2. Today we are treating type 2 dysfunction. Okay, we are mobilizing type 2. We are going to manipulate type 2. So that means they're either going to be fixed in a closed position or an open position. We leave type 3. Now, Grakovetsky, he talked about the spine as an engine. Okay, so the spine and an engine, as an engine. I am going to show you this video. And so if you're interested, the video is probably like, I'm not going to play it, all of it. It's only 30 seconds. But if you go into YouTube and type in Grakovetsky, then you will see the video. And it's worth watching. Okay, it is worth watching because he explains how the motion of the spine, where it's originated from Lovett. Okay, he shows you demonstrations of. He talks about the disc, the concentric rings of the disc, and how they work almost like as a recoil effect. Okay, to allow the motion of your spine. So the disc is dehydrated, and you don't have that natural nucleus within. Okay, then it will affect the motion of the spine, and then cause facet irritation and all sorts of stuff. Okay, so you need like healthy discs. Okay, so when he's walking, where the screen is covered now, you cannot know, you do not know, but he's got no legs now, okay? Yeah. But when he is walking, he's using his spine, his pelvis, and his vertebral column as motion to ambulate. Okay, that is what Rex is on about, okay? You know, are you able to move without your arms and legs? And he shows that, yes, you can, okay? Because it's the motion of the spine. And then if I just let her just play it there. So he's Grakovetsky, okay? So when you see it, and then he will talk about the rod and the spine, and he explains it really well. So if you get a chance, you got 10, 20 minutes, yeah, then do that. Now, we take it for granted, okay? We take it for granted that we can walk up the stairs to come here. We take it for granted that we can go for a coffee, yeah, later on this morning. But if you've got like an issue somewhere, not so much in your spine, but in your hip, or your knee, or your ankle, or your foot, or your great toe, okay, then anywhere is going to restrict the gait cycle. And we're obsessed, okay? You know, think about Facebook and people on there. You know the people I mean. We're obsessed about how many steps we walk a day, okay? Yeah, you know, someone, you know, you were friends, but I walked 8,451 steps today. You know, and there's like 50 comments like, well done. Yeah, well done. You know what I mean? So, but people, you know, I'm sure we are all responsible in some way or another. But 10,000 steps a day means 10,000 gait cycles. 10,000 gait cycles, you're either on one leg or you're on the other leg. but we take it for granted. Add on an arthritic hip. Try doing 10,000 steps. It ain't going to work. Okay? Try adding on a meniscal tear to the knee. Okay? And you're like, oh my God, how far am I going to walk to the shop? Okay? Try adding on, like a lady was here yesterday and she had some surgery to her foot. Okay? Karen. Okay? So, she probably wouldn't want to walk to town and back. Okay? Yeah, and she's got crutches and all that stuff. Okay? Because she's got an issue with one side, but if you carry on, you'll have an issue with the other side. So we take the gait cycle for granted. It is roughly, according to the podiatrist, who we have a specialist here, okay, yeah, it's roughly a 60 to a 40. 60% in the stance phase, 40% in the swing phase of gait. And you can see here the purple, okay, the pelvis is posterior, and as we go through the mid-stance to the swing phase, it goes from posterior to anterior. But briefly speaking, if you're looking at, say, I'll do this one. The positioning of your leg is important because this generates the motion of your pelvis, which generates the type 1 motion of your spine. Okay, so we need it to allow the spine to move in its normal motion. So the pelvis is posterior, the hip is flexed, the knee is extended, the ankle is dorsiflexed, and the foot is inverted. Easy enough. Yep. There are some muscles that are located, which is I'm going to look at here. So when we hit the ground, the tibialis anterior and the tibialis posterior will hold your foot up and in preparation for you to hit the ground. All right? Now, the tibialis posterior, where does it attach to on the foot? Okay, the tibialis anterior. Okay. So tibialis posterior, okay, so it basically will go to most of the bony landmarks on the foot, I think, apart from the talus and the first metatarsal. Okay, so it connects. It's mainly like to the navicular tuberosity. Okay, and then there's a little shelf called the sustentaculum tali. Most of the metatarsals, the cuboid, etc., etc. Okay, so it's like a glove that comes under the foot. Okay, it's like an amazing stabilizer. The tibialis anterior comes down, and the tibialis anterior will go to the first metatarsal and the medial cuneiform. But it continues, okay, into the peroneus longus. Okay, so it's almost like a little stirrup. So tib ant, okay, comes down and under, continues into the peroneal longus. The longus doesn't stop at the head of the fibula. It continues as the bicep femoris, and it doesn't stop. It connects to the ischium and connects into the ligament called the sacrotuberous ligament. Okay, so it's a fascial sort of connection to that. Now, that ligament, you can see that it's on stretch because the pelvis has gone back, so it's on stretch. On the right-hand side, it's gone back, but on the left-hand side, it would have gone forward. Okay, so the movement of the pelvis, so when you are walking, okay, this is exaggerated. So if the right side has gone back, the left side's gone forward. So literally walking will be this motion. Okay, anterior, posterior, or the innominate bones. When I say innominate, it is the ilium and the pubis and the ischium that's conjoined to be one bone called the innominate. Okay, so we'll call it the innominate, which articulates on the sacrum. So it's basically the IS joint, okay, so the iliosacral joint, rather than saying the sacroiliac joint, because it is this bone that's moving on the sacrum, rather than the sacrum moving on the ilium. Okay, so it's the iliosacral rather than sacroiliac. One would argue it's the same, but they are sort of independent of each other. Now, as you are moving, it is a continuation of a sling. This is a sling by Andre Vleeman. He was a professor at 26. Not the Myers sling, even though there's an overlap. Vleeman has 4, Myers has 13. Okay, so 13 slings, to explain, takes a bit longer than 4. So there's a connection. So when you are walking, you activate this sling. This sling is utilized to stabilize the pelvis. Okay, so it's utilized to stabilize the pelvis. So as soon as you bring the leg forward, this pre-tension of this sling is causing the pelvis to basically close. They use the word force closure. So where the purple boxes are, which is the innominate, the orange is the sacrum. If you just stood on the left, that would be what we call a form closure. So you don't need to go from 10,000 steps on each leg. Okay, so when you walk in, we need another system called the force closure. So we need something that will assist us in stabilizing the pelvis, allowing the motion of your spine. Okay, because if things don't work very well, like if you've got a knee that doesn't extend, or a hip doesn't flex, or a glute med that's a bit weak, it's going to affect the motion of your spine. My back hurts, but it's my knees that's the problem. My back hurts, but it's my big toe. My back hurts, but it's my hip. Okay? And if you just treat the back without looking at the gait cycle and looking at the hip and the knee and the ankle and foot, okay, then you'll keep treating the back. Yeah, but then by looking at the knee, a change of position, the lower back might reduce. Okay, so it's not always about, treat the symptoms, try to find the causative factor of the problem. Where the pain is, the problem is not. The only person interested in pain, okay, is your patient. You should be chasing dysfunction rather than chasing pain. But John, it's my shoulder that hurts. Why are you treating my my right gluteus? Because of the link of the fascia. I know, but can you just still rub it a little bit? Because it does hurt. I can do a little bit on it. Can you just do a little bit more because it's really sore? I know, but it's not from there. It's from there. I know it doesn't matter, but can you just do a bit more now? And that's all, we ask. Now, so the idea is that we want to try to give stability to that sort of pelvic sort of area. Now, the sacrum, I'm going to just do this one. So this is theoretical. So when we are walking, the pelvic bones are going forward and backwards. But the sacrum rotates in a transverse plane. So it rotates on an axis. So it rotates on the right axis and rotates on the left axis. So when it's moving, remember I already said, whatever the sacrum is doing, the lumbar is doing the opposite. Okay? So it is like a cog in a wheel. Okay? First cog, second cog goes the opposite. Third cog goes the same way as the first one. Okay? So when the sacrum is moving, the second cog, which is the lumbar, will go the opposite. And the third cog, which is the thoracic, will go the same way as the first one. So it's like a drive train. It is automatic. There's no muscles on the sacrum, but obviously crossing, but not controlling it. The movement of the sacrum is driven by the gait cycle. The innominate bones rotating is driving the sacrum into a rotation. Okay, let me give you an example of this one. So it's a rotation. So the sacrum is rotating to the right, comes to neutral, rotates to the left, comes to neutral. That's what it does. There is a video, I'm not sure, I might play this. Okay, so the sacrum is rotating to the right, comes back to neutral, rotates to the left, comes back to neutral. Okay, so it goes to the left. And I'm going through these quite quick. Okay, so it's important that you understand it to a point. So the sacrum rotates one way. So the problem is if it gets fixated, it then affects the lumbar. If it's fixated, it affects the lumbar and the thorax. If it's fixated, it affects the lumbar and the thorax and the cervical. Okay, because it has to have a knock-on effect. So the sacrum is the sacred bone. It is the keystone. Okay, it might be the missing key in the door. Okay, and you want to maybe look at that and focus on that. You're not really going to get pain in the sacrum. Okay, but if the sacrum's not moving, Maitland says the ability of walking is for the sacrum to rotate to the right on the right axis, come back to neutral, and rotate to the left on the left axis. And that's what he says. So when we add in the sacrum and the lumbar together now, you can see that as the sacrum is going to the right, it drives the lumbar to go to the left with side bending to the right. So it's a type 1 motion. Sacrum rotates right, lumbar rotates left. Thorax rotates right, the same direction as the sacrum. Add on the pelvis. Okay? So as the innominate now is going forward and backwards, the green bit, so if that sacrum is coming back, if the innominate comes back, the sacrum goes forward. But it just doesn't go forward, it goes forward to the right. Okay? And obviously this sacrum on that right side is going forward, so the sacrum inferior on that side is coming back. So the left side is going forward into nutation, the right side of the sacrum is coming back into counter nutation. Okay, but don't worry about it too much. As the innominate is going forward, it just drives the sacrum and the lumbar is rotating the opposite side. So this is looks like more complex. I'll leave this aside. If you want to have a play at break time, just to dig, and take some photos, that's fine. But remember, if you want this, as a PDF, I can send you the chapter. So, okay, you can see the bicep femoris directly merges into that sacrotuberous ligament. It's not stop and finish, it's a continuation of. And then you can see that if this innominate here, okay, comes back, so it's in the swing phase, it will allow the sacrum to go forward to the left, so it rotates to the left. And the other leg would be in the stance phase of gait. Now, what we're going to look at now is different dysfunctions. On page 10, on 11, on the top, it will say, if you've got a facet joint that is fixed closed, because of the position of, we will call it an ERS. The ERS, the E will stand for extension, the R rotation, S side bending, either to the left or to the right. So one vertebra, okay, so L4 has gone back, rotated, side bend on L5. Okay, so ERS right or ERS left is one vertebra in dysfunction on the other. And vice versa, if it's gone forward, it is in flexion, rotation, side bending, either to the left or to the right. Have a look at the first picture you've got. Turn over. When you assess the spine, you've got 4 pictures there, okay? The first picture, look at the top dysfunction. It says ERS left. Can you see it? So it's already telling you what the problem is. Now, it looks confusing, and it is. But if you split it down into stages, you've got the spine in neutral, the spine in extension, the spine in flexion. Look at the right-hand side, okay? The spine is in neutral, the spine is in extension, the spine is in flexion. Okay, so when you're assessing the spinal position, you should test in 3 positions. So the person's flexed, the person's neutral, the person extends. So you test them in 3. Okay? I've already told you what the dysfunction is. Let's say we start, let's say this is T4, T5. Okay, so thoracic level number 4 on thoracic level number 5. But we've asked, let's say for instance yourself, so let's say this lady here, we've asked her to start in extension. Okay, so so the spine of the scapula will come across to about T3. Yeah, let's say it's T4, doesn't matter. So around here. So if we bring our thumbs lateral to the spinous process, roughly 2.5 centimeter lateral, so you are going to drift towards the transverse process here. So we bring our thumbs lateral, normally do it this way, okay? And then you feel, is the left thumb equal to the right thumb? If a patient's in extension, okay, so let's say you extend, okay, so she extends, and you notice your thumbs are L, which is level, okay, and then you ask your patient to go from extension to neutral to flexion, you notice that the left thumb is more shallow or prominent, and the right thumb is more deeper, so it goes in away from you. And as you go into further flexion, it's more obvious, okay? Let me give you an example. So I'm T4, below me is T5, okay? This facet joint, okay, I got a facet joint here, the superior, okay, and I got a facet joint here, the inferior. So let's say this one's stuck on this side. So in extension, both facets are closed. But from there, as I go into flexion, this side opens as normal, but this side cannot open for some reason. So what happens is, as this side starts to flex, this starts to become a pivot point. So this TP is being pushed back, hence why you can feel it, and this TP goes away from you, and that's why you cannot feel it, and it goes deeper. So it goes away from you, okay? So this is the problem. So the facet joint is fixed on the left, so the T4 is in a position of ERS on T5. All right, we'll do some example shortly before we, because it's better to say, you know, I understand it, I want to assess it as I treat it, because if you just treat in, because many people come to me and they say, John, can you watch me manipulate, say, T4, 5? I go, yeah, okay. Yeah, I said, what's the dysfunction? Oh, I got no idea. Yeah, it feels a bit stuck. Stuck left or stuck right? Is it open or closed? I don't know, John. Okay, can I show you the lumbar manipulation? I said, what level? I don't know, I'm just doing it. Okay, I'm just doing it. I said, it's not so easy, okay, because if you have a problem and you're sued and you go to a court of law, okay, and you are there on the stand, yeah, and I'm interrogating you, yeah, and I will say, okay, so you manipulated your patient. What assessment did you do? I didn't do one. Okay, what level did he manipulate? I don't know, I just did it. Okay, you're asking for trouble. Okay, whereas if you said, I ran through my assessment, my history taken, I run through my motion palpation testing, I believe, yeah, through my training, with John say, Yeah, but I thought the T4 was fixed closed on T5. He taught me to use a towel to lock T5. I locked it. I asked my patient to breathe in, breathe out, and I did a little adjustment, and I felt a cavitation. And the patient consented to the treatment, and she said afterwards she felt better from what I did. And it's all written down there, okay, in red, okay? And that's what I did. I'll be like, ah, well done you. Well done you, no problems there. Yeah, thank you very much. But if you said, I got no idea what I did, I just cracked the back, and I got a big crack. It was really loud, okay? But you caused a problem. Okay, you know what I mean? You were asking for trouble. Okay, so that's why it is better, whether you like it or not. This is the way I teach the course, and I think it's better because at some point you might find something might happen with someone, okay, and they contact you saying, oh, my back is worse since, and you go, well, you know, you signed for, you consented. This is what I found, etc., etc. So you carry on, okay? Because if it goes to a court of law, insurance, you're like, well, I've got everything documented here. So just that's why I would teach this. Yeah, no offense to the OMT, but it's to say, let's just get on with it. Yeah, okay, but I think it is better probably to learn it. Yeah. Now, next one, we're almost there. So the ERS to the right is exactly the same. So the dysfunction, T4, let's say L4. So L4 gone back to the right on a vertebra below. So if you started in flexion, okay, so if you ask them to flex, there will be a shallow side. A lot of osteopaths might do that. They'll say flex your spine, and they will bring your thumbs lateral to the spinous processes and see if the thumbs are level, yeah, as they are coming down. But if you started in extension, the thumbs will be neutral. I'm going to show you an example in a second. Now, an FRS, turn to the third page. This is a little bit different. So there's only two dysfunctions we are looking at. It's either closed left or right, or open left or right. Okay, that's all we are looking at. So the person this time will be more likely in flexion, and they cannot extend. Think about this, okay? Patient is sitting like yourself, and as you go to stand up, what happens to your spine? The spine goes from, so as you are sitting, the sacrum is more likely counter-nutated, the lumbar is flexed. And as you go to stand up, you reverse the curve. Okay, so the spine will go from flexion to extension. The sacrum goes from counter-nutation to nutation. So if you cannot say, when you go to stand up, you're like, oh God, I'm struggling to stand. The vertebra is struggling to close. So the vertebra might be open, open. Either open, in this case, to the left. Now, the vertebra is held in flexion, rotation left, side bending left. So the facet joint on the right is open. Okay, even though it's gone to the left, it is the right side that's open. They're both open, but the right side is more open. So when you ask the vertebra to come back up, so when you ask them to extend, which they might not be able to, but if they are able to extend, because there's only one dysfunction, only one level, not 3 or 4, just one. You might notice in flexion, they are level, but the picture before, they were asymmetric. But now, when you ask them to extend, okay, when you extend, there is asymmetry. Whereas the picture before, in extension, they were level. Okay, this is a mnemonic I would use, or a little phrase I use. So in flexion, so if you flex the spine on your patient and there is a shallow side, a prominent side, it is fixed, closed. Okay, so the treatment will be to open. However, if you ask your patient to extend and there is an asymmetry, okay, then it is the deep side, not the shallow side, the deep side that's fixed open. Let's look at an example. You got it? So this works for me. I'll show, when we have a break after, I'll show you. Okay, so patient. Let's say it's a T4-5. Neutral spine. Left side shallow, right side deep. You ask the patient to flex. Left side even more shallow or more prominent. The right side goes even deeper in flexion. You ask a patient to extend, the thumbs are now level or symmetrical. So you've tested the thoracic level in 3 positions. So what do you think the dysfunction is? Which one? ERS. Left or right?
Right. Deep. No, left, because it's deep on the right.
So the dysfunction would be T4, T5, ERS left.
Left.
Let me just recap here. Okay, so we start neutral spine. Okay, so patient in neutral. Left side shallow, right side deep. So the key one, so when they flex, we have a shallow side. Remember, in flexion, the shallow side is closed. So when we extend, they become level because they both can close. But when you ask it to flex, the left side stays closed and the right side open, so it's like a compass. It becomes a point of pivot to the left. That's why it becomes more shallow. Okay, so T4. So the left inferior facet of T4 was fixed in a closed position on the superior facet of T5. So it's called an ERS left. You can simply say it's fixed closed on the left. It's fixed in extension on the left. If you want to use the ERS, you can. So this is the picture, just to recap. Okay, so T4, 5, the left side was closed. And the key movement was the flexion. Okay, one more. In fact, this is me out to open it, but there's no volume in this one, so I'll leave that one. Okay, so lumbar spine. Okay, so now you palpate, say, L4, 5 or L5, S1. So neutral, right side shallow, left side deep. So you don't know yet. You ask a patient to flex. You notice that the thumbs seem to become more symmetrical in flexion. When you ask a patient to come up onto the elbows like you read in a book, you notice now the right side is still shallow and the left side is still deep in extension. What was that? What was that? Flexion lesion. Okay, let's go back through it again. Okay, so left side, so neutral, right side shallow. So basically either the right side is back or the left side's gone forward. Okay, but you don't know yet. So that's why you would do the flexion. So they're happy to go into flexion. But as you ask the patient to extend, the facet does not want to close because it is fixed open. So it is a FRS right, but the dysfunction's on the left. Okay, so it's gone forward to the right. Let me show you a picture. Okay, so this is the dysfunction. So the key movement is extension. In extension, we've got a deep side. So the deep side is fixed open. But the vertebra is rotated to the right. So you don't have to worry about the FRS to the right. Just say it's open on the left. Okay, it's closed on the right. Yeah, if you want to. On YouTube, I do show one where I close the facet, where I do a side bend technique on the neck, but that's not really part of this course, but it would be an example of. Any questions? I think I went through that quite quickly. Yeah. We will, after the 10-15-minute break, okay, coffee, which I'm not sure if it's open, but it's not.
There's these shops.
There's a shop round to the right if you wanted to go. We will do some practical, yeah, to consolidate this bit. And then we will mobilize to open, close facet. and then we will obviously manipulate before lunch. Okay, so I give you options of mobilizing and manipulative.